laparoscopic hiatal hernia repair with Nissen fundoplication for patients of Northwest Minimally Invasive Surgery. The content of this video may not be reproduced without written consent by Northwest Minimally Invasive Surgery. This is a general overview of the anatomy. As you can see in this diagram, the esophagus is the swallowing tube that connects from the mouth to the stomach. The esophagus goes through a muscle called the diaphragm to join up with the stomach. The diaphragm is a muscle that separates the chest from the abdomen. The opening in the diaphragm that allows the esophagus to go from the chest down to the abdomen to join the stomach is called the hiatus. A hiatal hernia is when the normal small opening in the diaphragm gets much larger. Because this opening is stretched wider, it now allows the stomach to travel up into the chest. To fix this problem, we perform a laparoscopic hiatal hernia repair with Nissen fundoplication. It is done in the hospital setting under general anesthesia, which means that you will be completely asleep for the entire operation with a special tube in your airway to assist with breathing. This is necessary for laparoscopic surgery. You will be carefully monitored throughout the entire surgery by an experienced anesthesia provider. The surgery itself can take 2 to 3 hours to perform. This surgery may be completed as an outpatient operation depending on your age and medical conditions. The first step of the operation is to place a small needle near the umbilicus into the abdominal cavity and inflate it with CO2 gas. This allows the abdominal wall to be lifted up so we can see inside. After inflating the abdominal cavity, we place 5 access ports, which are small plastic tubes at these various locations to allow us to pass a camera and instruments into the abdominal cavity. These instruments allow us to complete the operation from the inside of the abdominal cavity without having to make a large incision. These incisions for these access ports vary in size from 1/4 to 1/2 inch. The first step in the operation is to restore the stomach and esophagus back to its normal position in the abdomen. In order to do this, we place traction on the stomach and pull it down below the diaphragm back into the abdomen. We have special cauterizing devices that allow us to divide attachments around the stomach to get it out of the chest. The second step of the operation is to close the hole in the diaphragm. We do this to prevent the stomach from sliding back up into the chest. The diaphragm opening is closed tightly around the esophagus using sutures. We may reinforce the sutures with mesh to help give it strength. If used, this mesh is a biologic product that does not cause any reactions. The last step of the operation is to stop the reflux with a procedure called a Nissen fundoplication. The Nissen fundoplication is designed to stop reflux from occurring. This procedure involves taking the top part of the stomach and wrapping it around the bottom of the esophagus. In order to do this, we reach behind the esophagus and grab the top part of the stomach and drag it underneath. It is then flipped on top of the esophagus and sewn in place. This tightens the bottom of the esophagus and creates a high pressure zone in the bottom of the esophagus that acts as a valve that prevents reflux from the stomach up into the esophagus. In terms of risks from the surgery, it is not uncommon to experience some bruising or bleeding at the incision sites. This typically is right around the time of surgery and resolves on its own within a few weeks. Major intra-abdominal bleeding is very rare. Infections are also rare. We give a dose of antibiotics prior to the start of surgery to help prevent infections from occurring. There is a small chance that the stomach or esophagus can be injured during the procedure. We perform an endoscopy at the end of the procedure to help evaluate for this. The vagus nerve runs on the top side and back side of the esophagus and can be injured during the procedure, although very rarely. Fortunately, if this does occur, most people will not notice any changes. Despite a successful surgery, these operations can fail. The failure is usually due to the hiatal hernia repair weakening over time, and this can occur up to 20 to 40% of the time. This may result in recurrence of symptoms. If this does fail, the surgery can be redone again. Other complications such as heart issues, blood clots, pneumonia, and general surgical complications are fortunately very unusual. This procedure is not without side effects. Fortunately, the vast majority of these issues resolve with time. It is not unusual for it to take up to 6 months for these to get better. Please be aware that some degree of these side effects may always be present. Patients can find it difficult to belch or vomit, which can result in trapped air in the stomach that needs to pass out from below that can result in more flatulence. Often bowel movements are different for the first few months after surgery and can really range from diarrhea to constipation. This is a result of medication changes and changes in your diet. It eventually normalizes with time and can take several months. Initially after surgery, it is often difficult to swallow. Therefore, we will need to modify your diet right after the operation. For the first 2 weeks after surgery, we recommend a straw diet. This includes anything you can get through a straw, such as soups, smoothies, yogurt, milkshakes, and juices. If you're doing well after 2 weeks, we can advance you to a soft diet. This includes foods like scrambled eggs, oatmeal, mashed potatoes, cream of wheat, mac and cheese, and ground meat. Continue on these foods until they are easy to eat and you can advance your diet from there. It is not unusual for it to take 6 weeks to find that foods are more normal. The key to eating is small bites. The bite should be about the size of a baby teaspoon of food. Chew well. Typically, it takes 10 to 20 chews before swallowing a bite of food. Eat slowly. The best way to eat is very, very slowly. This means that you should take at least 30 seconds between swallowing bites of food to allow the food to pass through your esophagus into your stomach. If you follow these rules, then eating will be much more comfortable. If you do not, you may experience pain, regurgitation, and vomiting. The recovery period varies from person to person and can range from 1 week to 1 month or even longer. There are no specific activity restrictions other than pain or discomfort. For the first few days after surgery, it may be uncomfortable at the incision sites. Therefore, it is recommended to take it easy until the pain goes away. Once the pain is gone, you can do whatever you want and have no restrictions. The best thing to do is to simply listen to your body. Shoulder pain is also very common after the surgery and is due to what we call referred pain. It is related to stretching of the muscles of the diaphragm and abdominal wall due to the gas. It is often described as gas pain. Also, the gas will travel up into the chest space and result in significant chest pressure and pain. This is all normal and typically goes away after several days and is improved with walking and deep breathing. A heating pad may also help. In terms of returning to work, I would advise you to wait until you are comfortable and the pain is gone. Depending on the type of work you do, it may take several days to several weeks to get back to work. Please call us if you have any of these issues. We are available 24 hours a day, 7 days a week, and 365 days per year. Thank you for choosing to have your surgery with us at Northwest Minimally Invasive Surgery. It is our goal to ensure that you have the highest quality surgery with the best outcomes and are committed to providing you a great experience. Thank you.